Hey, it's David Williams here, host of the Health Biz Podcast. Today's episode features Niall Brennan. He's the CEO of the Healthcare Cost Institute, and he uses his perch there to call out the moral and ethical failures of the U.S. healthcare system. Whether he's talking about insulin pricing, air ambulances, surprise billing, or the pandemic, he brings a sharp wit and a deep reservoir of healthcare knowledge. Brennan's been around the block in healthcare. Before Hcci, he was Chief Data Officer at the Center for Medicare and Medicaid Services, and he was also a staffer at Brookings, MedPAC, Congressional Budget Office, and the Urban Institute. So his perspective is from someone who knows what he's talking about. I really enjoyed sitting down and talking with Niall, and I think you'll enjoy this episode of Health Biz. If you do, remember to subscribe. Niall, it's great to see you today. How's it going?
It's going great. The weather is still beautiful. Winter has not yet come in Game of Thrones parlance, so I'll take it.
That sounds good. I was reading about, I'm glad I got you at 3 o'clock because I was just reading in the newspaper that 5 o'clock is now the time for dinner. That's like going out before it gets dark and before it gets too cold. So I'm glad I caught you before then.
Exactly.
So Niall, tell us what's your background?
Gosh, where do I begin? Maybe at the start. Well, I grew up in Ireland. Lived in Ireland as a teenager through the 80s and 90s. Got my undergrad there. Was part of the massive demographic bulge in Ireland when I was an 18-year-old. 50% of the population was 25 years of age or younger. So it created this huge stress on a very excellent Irish education system, and actually was a lot of the seeds for the emergence of the Celtic Tiger. Because when a lot of these overseas companies came in, they found a very highly educated, technology savvy, English speaking workforce. Obviously, because I'm a little bit of a contrarian, I chose to leave just as the Irish economy embarked on an unprecedented economic expansion and subsequent contraction.
Well, it's sort of, your departure sort of like benefited both countries, right? Is that how we'll look at it?
Exactly, exactly.
Yeah.
And I somewhat serendipitously won a green card lottery and a scholarship to study to be at grad school in Georgetown within 6 months of each other. So I came to Washington D.C. in '94 to start a master's in public policy, and it is late 2020, and I am still living in Washington D.C.
Outstanding. Well, I got out of there when I could. I grew up in Bethesda, and it was sort of in and out. I was only there for maybe 15 years. So, so we'll see how it goes. Now, I was wondering, the name Niall. You just explained it because you came from Ireland. I thought it was maybe from Nile Care, which is kind of a big bad HMO back in the day. But
I remember Niall Care. In fact, somebody in my MPP program, whose name I'm blanking on, worked at Niall Care.
no kidding. Yeah. Well, they used to call it denial care. Not very original, but I see that's the connection. All right, so that's pretty good. So now you got out of grad school, stuck around in DC. I see a lot of DC jobs there on your resume. What was that all about? Think tank, government, back and forth. What's the story?
Yeah, I mean, I guess I'm just like kind of a nerd. I mean, again, one of a very early memory is when I was 12 or 13. Again, back at school in Ireland, there was a substitute teacher came in, and I think out of desperation to teach us something, he gave us a little quiz to see if anybody could name government ministers in Ireland. And you know, I was the only kid who got 18 out of 18 or whatever the number was. Like, I was actually a relatively indifferent student, but for some reason I had this, fascination with government and policy. So ended up at Georgetown, got my MPP, and I'm not going to lie, DC is kind of my town. I've been fortunate to work at a lot of great places like the Urban Institute and the Brookings Institution, Congressional Budget Office, Medicare Payment Advisory Commission. And what I love about all those places is, they're all trying to do the right thing, trying to make healthcare better to the extent that they can. But B, they're just like so full of incredibly smart people, and it's just I get a real kick out of frankly, going to work and knowing that frequently I'll be the least smart person in the room, because that means that, the quality of discourse is really going to be quite high. And so I've, remained friends with people from across the arc of my career, and I'm just like incredibly fortunate to do so. Just a lot of really, committed, smart people.
No, that's 'cause like a nerd it's a nerd's paradise there. So, yeah, I remember going to high school, public high school, and my lab partner, in biology, his dad was almost a Nobel Prize winner, and he's a, major, professor at, UC Berkeley. So, they get the whole package, and it's good. You don't have to be the smartest one, you just have to be the smartest at picking your lab partner.
Yeah, and aside then from the nerd factor, DC is generally just a great town to live in. It's super diverse. There's people from all over the world, all kinds of different backgrounds. So even from a place to live perspective, there's sort of never a dull moment. You're not too far from the sea. You're close to the Shenandoah Mountains. You got Rock Creek Park in the middle of the city. So it's not all about work either. The summers do get a little bit. Uh, Hot for somebody of my genetic disposition.
Yeah. Fair enough. Well, the summers are for leaving DC. So, all right. So now HCCI, Healthcare Cost Institute. That's where you are now. What is that?
It's a small but mighty nonprofit with the quixotic goal of trying to stimulate a national conversation or change the national conversation around healthcare costs. We have a serious healthcare cost spending problem in this country. I think everybody agrees on that. I mean, again, I remember when I came here first and started grad school in '94, healthcare as a percent of GDP was probably 12 or 13%. And people were like, that's it. If it goes up one more percentage point, the world is going to end.
Yeah.
Fast forward and we're at 18, 19% with no end in sight to the climb. So what I think our particularly unique contribution is, because look, anybody can, DC is full of smart people, and it's full of small nonprofits with different missions, and anybody can pontificate about healthcare spending, and some do it well and some do it less well. We try and bring data to the debate, and specifically we try and bring data for people who have employer sponsored coverage. So everyday working Americans, or at least those who are still fortunate enough to get healthcare coverage through their employer, this was a historically under analyzed population, just because, again, of the structure of the US healthcare system. Some people have United, some people have Aetna, some people have Humana, some people have a Blue plan, right? So we were established about 10 years ago when United, Aetna, and Humana came together and said, look, even though we're fierce competitors, we believe that there is sufficient value and public good in pooling our data with an independent, trusted third party, and having that third party organization A, analyze the data themselves, and B, license the data to academics at universities, so people can start to dig deeper on exactly what is driving spending trends in that population.
That sounds very reasonable. But what are the priority topics there? You're talking about the people who are commercially insured as the focus, but where, particular topics that you're narrowed in on?
Well, first of all, we focus on top line spending, and we kind of take it from there. We can, we look at inpatient, outpatient, professional prescription drugs, and in recent years, we've tried to make a particular contribution around the area of surprise medical billing, prescription drug prices. Our work on insulin price increases is by far are the most cited piece of work that we've ever done. There's a lot of debate around all payer rate setting and single payer and public options. So again, we have the ability to compare the rates we see in our data to the rates we see in Medicare data. So there's really very few healthcare debates that don't benefit from us kind of bringing data to the table. And I really think that's a big difference maker, because again, people can debate all they want, but we can bring hard numbers to the table that people can react to, or people can use to understand the implications of different policies and procedures, or also focus on some of the frankly outrageous behavior that happens in the US healthcare system, not necessarily among all providers, but among certain providers. When you see emergency department facility fees increasing by 100, 150, 175% over a 5, 6, 7 year period, I mean that's just unbelievable. Like you wouldn't see that in really any other sector of the economy.
So let's talk about a couple of these things that you mentioned. They're all very juicy topics. The surprise billing, surprise. That's not a good surprise typically. How do you frame that one? Because consumers don't like to get a surprise bill, but on the other hand, the physicians have their perspective on it, and the health plans have their perspective, and you've heard it in Congress as well. How do we think about it?
So first and foremost, I do think, and not everybody agrees with me, is that it needs to be framed as a moral and ethical failure of the U.S. healthcare system, and in many respects, it's a microcosm of you know how far we've descended, sort of among these warring tribes, and how frequently the consumer or the patient is caught between the warring sides and ends up being the victim. So, the bottom line in this whole debate is there are groups of specialists, many of whom have received significant levels of private equity investment. So, like groups of emergency room doctors or groups of anesthesiologists, and as far as they're concerned, the health insurers are not paying them enough, so they're not giving them rates that the ER doc considers sufficient to do business. But where the real kind of market breakdown happens, or the real kind of the way a consumer ends up being caught between a rock and a hard place is um, the consumer will go to a hospital that's in network with their health insurance plan. But while they're at that hospital that's in network, there is a significantly greater than non-zero probability that you will be seen by a physician that is not in network. And
Yeah,
so,
there's a surprise for you, right? When
yeah,
you when you when you find out, I went, yeah.
a very, very unpleasant surprise. And so, when you have a situation where people go to an emergency room, and whether it's for a serious condition or a trivial condition, not everybody makes the right decisions in seeking care. But should you really expect to have to go to an emergency room and be faced with a two, three, four, five, $10,000 bill a couple of weeks later because whatever physician you saw is not a network? Nobody lets you know this when you're in the emergency room. Plus the fact, like, even if they do, in the extremely unlikely event, let you know, it's part of a giant mound of paperwork that you're signing when you're nervous or upset or in pain. And the analogy really would be, if we had a situation where any American bought a car and 4 weeks later got an additional bill for $5,000 because the backdoor manufacturer was an out of network backdoor manufacturer, there'd be absolute uproar, right? And nobody would stand for it. And yet it has become an insidious and I somewhat accepted practice. I mean, there's a lot of um, I think there's a lot of tut-tutting and pearl clutching about how it's terrible, but the reality is despite near unanimous partisan agreement that something should be done about it,
Yeah.
we've been unable to do anything about it. Now that may speak to the general dysfunction and gridlock we're facing in American politics these days. And I know that, and I've been in rooms and had debates with ER docs and anesthesiologists who fundamentally, vehemently, passionately push back against my thesis, but that's my thesis.
Yeah, well, I think it's fair enough, and that it's not too different from mine, so that it make for a less interesting show, I suppose. But so, from a data standpoint, one thing that hasn't been clear to me is I know that as you say, the emergency docs, the anesthesiologists are often organized in such a way that they're kind of essentially refusing to take the insurance contracts. Now, from a hospital standpoint, the hospitals know or could know who's in and out of network in a typical place. Do the hospitals have a choice, and they're choosing to contract with the group that they know is out of network, or is it like if I'm hospital A in a town, I'm going to face this situation pretty much no matter which emergency docs or anesthesiologist I contract with. Do you have data that sheds light on that?
So my sense is, and I don't have great data on it, is in a lot of areas, hospitals may not have a choice or have a very limited choice. I'm not saying that happens all the time, but I would certainly hope that hospital administrators are aware of this issue and not willfully entering into contractual agreements with emergency room doctors that are out of network. But I think also a lot of the time, what's happening is, there's a kind of an element of stasis about it. So emergency room docs haven't always been out of network, right? I mean, this is a relatively new phenomenon. And so if you're a hospital who's been, happily doing business with a certain group of emergency room docs, and then they're acquired by a PE company, or maybe they make their own decision because they're not happy with their latest round of negotiations. There's that kind of stasis effect where you're like, well, sure, I could go out and look for another group of VR docs, but they might not be out there and it's hard. And I really like those guys. And again, I think a little bit of looking the other way. Well, ultimately, this is not my problem.
Yeah.
This is a consumer's problem. And I think that's a terrible attitude to have.
Yeah. So what's going on with diabetes and insulin? I remember in my not even my graduate program, but a sort of like first undergraduate, you have these trade-offs and you talk about things that are inelastic, and they always give insulin as the example of something where you could drive the price up because you got to have it. She's got to have it. You
Yeah.
got type 1 diabetes. So what's going on
You're
there?
type 1 diabetic, you don't take your insulin, you die. So look, again, this is, you know, it's either very simple or highly nuanced, depending on your worldview, right? Prices for insulin have surged over the last 10 years, more than doubled. I think where the nuance comes in is that the whole shadowy structure of pricing in the prescription drug industry often obscures what the true price is, and so this is, I think a really interesting example of the things that you can and can't do with data. So we come out with an insulin issue brief. We track prices over 8 or 10 years or something like that. I can't remember. We document the fact that prices have doubled, but in our data, we have list prices. Okay, and list prices do not or may not reflect the fact that insurance companies have negotiated rebates with either PBMs or directly from drug manufacturers that lower the cost of the drug. And so when this paper came out, we were eviscerated on social media by certain pro pharma researchers who were basically saying HCCI is putting its hand on the scale here. This is not kind of upfront, honest research, even though we had meticulously documented, throughout the paper that these were list prices and that we weren't including information on rebates because information on rebates was very closely held and not released. Trust me, if I had information on rebates, I would absolutely redo and adjust our analyses. But there are a couple of other different layers to this. The reality is that those rebates are frequently not actually passed through to consumers at the point of care. So it's benefiting insurers, but not necessarily consumers. And the reality is that a lot of consumers have high deductible plans. And if you're in a high deductible plan, and if you're in the first couple of months of a year, you are actually paying that list price for insulin. So the list before rebate price is hitting you where it hurts. It's hitting you in the pocketbook, and it's hitting you every month. Sure, after a couple of months, you might hit your deductible with your insulin spending plus other healthcare spending. So again, I think it's a very interesting example of the tribalism that occurs all throughout healthcare and all throughout life, and even healthcare research, that people are sort of completely willing to overlook the fact that yes, there are rebates, and but that they don't necessarily benefit consumers.
Well, a rebate is a weird thing because On the one hand, it's different from a discount because a rebate can become an income stream for an insurer. And there may be somebody who says, that's my revenue.
Exactly.
You can't mess with that.
Exactly. And so, when we think about, look, we're a small nonprofit, right? It's me and about 10 amazing, dedicated people who, crank out data analysis all the time. And so I think for a lot of organizations our size, impact can be really hard to measure. And, sure, we get quoted in the New York Times and the Wall Street Journal and local and regional papers, and that's great. Sure, I get invited to testify before Congress, and that's great. But when you think of true impact, a lot of drug companies, a lot of insurance companies have actually changed those policies in the last year and are now having consumers pay the post rebate price.
Hmm.
And a lot of state legislatures have introduced cost sharing monthly caps for diabetics to protect them from these egregious charges. So, look, I'm not taking credit for any of those things, but I am saying that our data, at least in part, contributed to a very vigorous and worthwhile conversation about how we had let this situation come to the state that it was in. I mean, we're probably the only first world country where type 1 diabetics die because they can't afford insulin. I'm certainly hard pressed to think of other first world countries where that happened. And I think we should be ashamed.
Yeah. So one way you leverage a smaller size and your data is working with partners. What's the partnership strategy? What does that look like?
So we have important partnerships with the people who give us data, okay? Because without the data, we don't exist. And actually, just so folks know, while we were established with data from United, Aetna, and Humana about 2 years ago, United and Hcci, there was a parting of the ways, as they say, and their data is no longer included in our data set. So we partnered with a coalition of Blues plans to add their data to the Aetna and Humana data. So, from again, a nerdy observation perspective, the data set actually got bigger. We used to have data on 43 million people. We now have data on 55 million people. So that new data set will be ready to go live soon. So those are kind of the back end partnerships. I think the front end partnerships are with people who care enough about HCCI's mission to make sure that we can do the work that we need to do. So very involved with foundations, in particular the Robert Wood Johnson Foundation, the Arnold Foundation, the Commonwealth Foundation, and other foundations have been very, very supportive of our work and enable us to do our work. Other key partnerships are journalists. When I came to HCCI, I made it a big, big priority to build bridges to the journalism community. I think there's a lot of great health journalism out there. I think there's a lot of great health data journalism out there. And so, to my perspective, it's kind of a mutually beneficial arrangement from a couple of perspectives. Often journalists have great ideas, maybe better ideas than me and my staff, but no data. And so, if I can, get them data and insights to support their great idea or investigation, that's a win-win. Slightly selfishly, it also gets us in the paper, which is good for the HCI
Yeah.
brand and keeps my board happy and stuff like that. But more broadly speaking, um, I think that some of the most important questions about healthcare spending have actually been asked by journalists and not researchers over the past 5 to 10 years, and I think that's a wonderful development because they have frankly, a much better sense of what's affecting everyday Americans from a healthcare cost perspective. And it's not necessarily a criticism of researchers, right? Their incentive structure is completely different. Like, a researcher gets rewarded for, you know, publishing a paper using 7-year-old data and some, esoteric econometric model, and their incentive structure is, well, if it gets published in an academic journal, that makes your department chair happy.
Yeah.
Does it actually push the ball forward and on how we change our healthcare system or expose the flaws in it.
So you've been at HCCI, I think, for 6+ years, and that's enough time to have been, I think, at the end of the Obama administration, all the way through almost to the bitter end of the Trump administration, and perhaps to the dawn of the Biden administration. What's different between these administrations as regards healthcare data, or does not make a difference who's in the White House from that standpoint?
Well, almost. I've been at HCCI 3.5 years. When we were talking about the earlier phases of my career, I probably actually left out the most important and influential career stop for me, which was 7 years at the Department of Health and Human Service in the Obama administration.
Gotcha. All
I
right.
became chief data officer at CMS and did a bunch of incredible and incredibly challenging things involving healthcare.gov and public data files and different things like that. Your question is an excellent one, notwithstanding that clarification. By and large, I think that things have been relatively consistent. Healthcare data is perhaps one of the few remaining truly nonpartisan things, maybe in our entire political discourse, but certainly in our healthcare related political discourse. And I say that on a day where the Supreme Court yet again debated whether to overturn the Affordable Care Act. So when I was at CMS, I was responsible for essentially creating data as a line of business at CMS, like changing the focus from, oh, data is just a byproduct of like, paying doctors, to data is central to everything that we do. And so part of that was, modernizing the agency's approach to how it used data in everyday decisions. And I think also very importantly, completely transforming our approach to how that elements of that data was exposed to the outside world, obviously with privacy protections and the like. So we had several major initiatives, open data initiatives, and I would say, largely speaking, the Trump administration continued a lot of those. And in one case in particular, the Blue Button program, I would say they accelerated it. So I had launched um, the what's called Blue Button 2.0, which is a mechanism to let healthcare consumers electronically download their healthcare information in the same way that you would download your credit card or bank information to your Quicken app on your phone. And so we had gotten to a certain point, and we sort of just couldn't get beyond that point, in large part because of complicated organizational dynamics. Healthcare.gov was such an overarching priority for the Obama administration, and I'm not saying it was inappropriately so, but just it meant that it squeezed a lot of other things out. When the Trump administration came along, setting aside their attitudes towards healthcare.gov, they took a particular interest in sort of, you know, making this blue button thing a reality, or like, pulling it across the finish line, if you will. I think the Trump administration has also really pushed the boundaries, frankly, on transparency, particularly transparency in prices between providers and insurers. I'm extraordinarily curious to see where all that ends up. The hospital facing transparency requirements are currently being litigated, and I fully expect the payer transparency requirements to also
Yeah.
be litigated. And then Biden administration, who knows? Hopefully, we'll have a Biden administration. There seems to be some recalcitrance on the part of the incumbents. So hopefully, common sense and sanity will prevail. But I would expect obviously pretty significant pushback where they can on anything Trump related. Expect to see a lot of reversing of executive orders and the like.
Yeah.
A lot more, a renewed focus on Obamacare. But the reality is that the Senate looks like it will retain a Republican majority.
Yeah. Ye have little faith.
Well, we'll see, right?
Get you down to Atlanta.
We'll see. If the Senate remains majority Republican,
Yeah.
The Mitch McConnell hasn't, I wouldn't expect his approach to governing with Joe Biden be any different to his approach to governing with Barack Obama, which did not seem particularly productive.
Yeah, fair enough. All right. Well, we'll have to come back and revisit these assumptions a little bit later. So I know you like to read mostly journal articles online, dusty old economics textbooks and so on. But what are you reading for fun? Anything to recommend?
I hate reading healthcare stuff.
Yeah.
Yeah, so I just finished an amazing book called Say Nothing, which
Mm-hmm.
um, takes a single event in the Northern Ireland conflict, euphemistically referred to as the Troubles by
Yes.
Irish people. So it takes the abduction and disappearance of a single mother of 10, and builds it into a narrative around the entire history of the Troubles. It was an absolutely fascinating, amazing read. I believe it was on many critics' best of lists in 2018. So I'm coming to this a little bit late, but that was absolutely fantastic. And before that, I read Jeff Tweedy's autobiography, the lead singer in Wilco, and that was also an incredibly charming and heartwarming book. I'm probably oversharing a little bit, but I was a huge Wilco fan back in the day. Myself and my wife saw them many, many times, and they were the first band to play the 930 Club in Washington, D.C. after 9/11. It was
Yeah.
about a week later, and it was an extraordinary moment, really. But I had sort of fallen away from the band a little bit, and just thought they were getting a little bit too pretentious, or call it. I read this book, and it was a revelation. I thought that Jeff Tweedy was a bit of a twit, but he is an amazing, self-deprecating, completely normal, very nice, albeit slightly flawed, like the rest of us person. So I would, both books, just like highly, highly recommend.
Great, excellent. Well, Niall, that is very good. So, as a reminder, I've been speaking with Niall Brennan from HCCI, by which I do not mean the Homogeneous Charge Compression Ignition, but rather the Healthcare Cost Institute. Niall, thanks for your time today.
Great talking to you.
You've been listening to the Health Biz Podcast with me, David Williams, president of Health Business Group. I conduct in-depth interviews with leaders in healthcare business and policy. If you like what you hear, go ahead and subscribe on your favorite service. While you're at it, go ahead and subscribe on your second and third favorite services as well. There's more good stuff to come, and you won't want to miss an episode. If your organization is seeking strategy consulting services in healthcare, check out our website, healthbusinessgroup.com.